continuous, non-branching, insoluble, rigid fibrils measure about 5 to 20 micrometers. On the light polarized microscope with the Congo red, it looked like apple green discolorations. And on the light microscope with eosinophilic state, it looked like eosinophilic staining. Amyloid, we have many amyloid in the body, but amyloid develop when there is failure of two mechanisms. Normally, the misfolded protein will be degraded by two processes, either intracellularly by proteasomes, lysosomes, or extracellularly by macrophage. If the failure of the macrophage or lysosome to digest this protein, we will have accumulation of this abnormal protein within the tissue. Classification of amyloidosis, we can classify them into, first of all, a systemic amyloidosis, which is secondary to chronic inflammatory process, like, for example, chronic pulmonary tuberculosis, bronchiectasis, and Mediterranean familial fevers. We have other amyloidosis, which include hemodialysis associated with chronic amyloidosis, other localized amyloidosis secondary to medullary cell carcinoma of the thyroid or, say, pancreas, also associated with localized amyloidosis. And we have AL amyloidosis and hereditary form, senile form, I will talk about them. This slide shows you type of amyloidosis, the precursor of each amyloid, and which tissue will be involved by this process, and what is the survival time. AL amyloidosis, it's the disease that affects the immunoglobulin, especially the light chain of immunoglobulin, result in involvement of the tissue body except the central nervous system is involved in this condition. A patient with AL will die within 9 months, especially if he has heart failure. While patients with familial type of amyloidosis, this is type due to genetic mutations in the amyloid protein, result in involvement of cardiac and central nervous system, and the patient may die within 5 to 10 years after diagnosis. We have senile type, and the other type I will talk later on. I will talk about the main two types of amyloidosis. We have what's called ATTR, what's transthyretin amyloidosis. This is classified into two main groups. One of them is wild type, the second is hereditary type. And the other one is light chain amyloidosis. We come to the light chain amyloidosis. What's light amyloidosis? This is abnormality in the immunoglobulin, in which there is disengagement of light chain, which is the lambda and kappa. It will disengage from immunoglobulin, start to accumulate, and misfold, result in involvement of the cardiac, renal, and GIT. While transthyretin amyloidosis, the transthyretin is a protein normally synthesized in the livers. And the main function of this protein is to transmit vitamin A and thyroxine. Unfortunately, it's tetramers. It will disengage to form monomers, and this monomers try to misfold, result in abnormal fibrils that deposit in the heart and peripheral tissue, especially the nervous system. In general, the clinical manifestation of amyloidosis include, which involve the heart, it will result in heart failure. The patient may present with atrial fibrillations and sometimes syncope due to bradycardia and heart block, which involve the musculoskeletal system, and especially I want to call the orthopedician, they have to look for amyloidosis in every person complaining of bilateral carpal tunnel syndrome. We have to think about amyloidosis in elderly patients who come with bilateral carpal tunnel syndrome. The other may have rupture of the muscle. We have to consider as amyloidosis as a cause of this condition. And peripheral neuropathy. معظم مرضانا they have advanced polyneuropathy, and they diagnose at idiopathic time. واكتشفنا انه this is due to amyloidosis rather than idiopathic time بس كان التشخيص نوعا ما متاخر. The other representation هو GIT manifestation chronic diarrhea. ايضا يمكن دكتور عبد الله احنا نبهنا على الموضوع انه if you are facing a patient with chronic undiagnosed diarrhea, please think about amyloidosis. والرجل بعد كده سنه 3 we discovered to be amyloidosis. شخص انه chronic undiagnosed diarrhea where it could be an amyloidosis. The other representation is erectile dysfunctions. Now we come to AL amyloidosis. As I mentioned initially, is a problem with immunoglobulins. It involves any organ in the body except the central nervous system. Usually 50% of patients will have cardiac involvement, and when there is cardiac involvement, the patient presents with severe heart failure and die within a very short period of time. Postural syncope may be due to autonomic dysfunction in this patient, while exertional syncope or syncope may indicate severe cardiac disease with fixed low cardiac output. The characteristic feature of AL amyloidosis, which is considered as pathognomonic sign, بنشوف المريض عنده what's called periorbital purpura. You have to think this patient has AL amyloidosis. It's pathognomonic sign for diagnosis of AL amyloidosis. This is what's called raccoon eye. It's characteristic features of AL amyloidosis. ATTR amyloidosis, as I mentioned, is a problem with the protein tetramers, which will disengage to 5 monomers, and this will be disfold, forming an insoluble fibrils that deposit in the tissue, causing a problem. So from the liver, this is tetramer, disengage for monomers, then it will be misfold, forming a fibrous abnormal protein. This is the characteristic of the heart in a patient who has cardiac amyloidosis. We have very thick wall involving all cardiac chambers, the right and the left cardiac chambers, even the interarterial septums, and even the valve, mitral and aortic valve, will be thickened by the involvement of amyloidosis. It's more common in males, mainly deposited in the heart. And in the past, they consider as benign deposit if you compare it with the multiple myeloma. 32% of patients above the age of 75 years with heart failure of preserved ejection fraction seem to have this disease. The genetic mutation type, there are about more than 110 mutations in the gene that's responsible for transthyretin, result in different clinical features depending on the type of genetic malformations. For example, patients with gene mutation V30M mutation presented with early onset of neuropathy. ويبقى المريض يختار بين النيورولوجيست as a neuropathy. Nobody think about amyloidosis. ويظن بعدين انه has amyloidosis. The other mutation V122I present with cardiac involvement, and 60% have neurological manifestations. So we have to think about amyloidosis. Please look at these red flags. It's very important because if we diagnose the patient early, we can improve the quality of life of our patient. If we have late diagnosis, no, the patient got no benefit from any treatment. So you have to think about amyloidosis if you are facing a patient with unexplained peripheral neuropathy. يجيك weakness, يجيك paresthesia, no identifiable cause, think about amyloidosis. Chronic undiagnosed diarrhea, also you have to think about amyloidosis. Bilateral carpal tunnel syndrome. Spinal canal stenosis in the absence of significant compression in the spinal canal. There is no disc prolapse, and the patient came to you complaining of spinal canal stenosis, you have to think about amyloidosis as a possible cause of intermittent claudications. Elderly patient with preserved ejection fraction heart failure, also one of the possibilities. Unexplained left ventricular heart hypertension, left ventricular hypertrophy. No, there's no evidence of hypertension, no evidence of aortic stenosis. We have to think about cardiac amyloidosis. Nephrotic syndrome, also one of the possibilities, and orthostatic hypotension. Unexplained hepatosplenomegaly, also we need to consider it. We come to the diagnosis. When you think about amyloidosis, what measure you need to reach a diagnosis as early as possible. Do I have a time or not? لا بعد تقريبا 5 دقائق. يعني رئيس القسم ما يخالف أنا رئيس القسم. Okay, we have ECG and echocardiogram. We have to do what's called serum free light chain assay, lambda and kappa. We have to do what's called serum immune fixation test and urine immune fixation test with imaging, MRI and technetium. And probably you may need biopsy. Nowadays, biopsies is uncommonly used for diagnosis. If you look to the ECG, we found this ECG, there's a hypertrophy by echocardiogram, but the ECG doesn't show any evidence of hypertrophy. So there is disproportion between the QRS complex voltage and the thickness of the wall detected by echocardiograph. You may see a bundled branch block, and sometimes you have pseudo-infarction as a possible ECG changes in patients with cardiac amyloidosis. Echo, very helpful for diagnosis. By echo, we can demonstrate there is biventricular wall hypertrophy, there is increase in the interarterial septum, there is diastolic dysfunctions and low tissue velocity with abnormal stain pattern, with normal ejection fraction, apical sparing by what's called LGL, a special technique I use it. This is the echocardiogram of patients with amyloidosis. If you look to the wall, it's very thick wall, the aortic valve is thick, and there is pericardial effusion. These are manifestations by echocardiograms. Global longitudinal strain, this one of the methods can be used by echocardiogram من خلال نحسب بالضبط بالدايستول والسيستول جلسة shortening بالمصل من خلال نحدد يا ترى dysfunction or not. In patients with amyloidosis نشوف انه البيز and the middle part of the ventricle are impaired while the apex is normal. We call it apical sparing, is characteristic feature of cardiac amyloidosis. And finally, we try to look for that. We have to do what's called isotope scanning. Isotope scanning, we give an isotope substances detected by gamma camera, and the basis of this test is that the amyloid protein will trap this material, and we compare it with the bone. There is a grading for this. For example, if we have the heart will take these substances, it's less than the rib, we call grade 0. When the substances in the heart less than the rib, we call grade 1. A grade 2, it's the bone and the heart have the same amount of trace, while in grade 3 is considered that the heart appears more dense than the rib. If you look to this, I think this is the third, grade 3, the heart is more dense than the rib, which is considered as positive. So grade 2 and 3 considered positive for amyloidosis. A very helpful test in these conditions. Sometimes we may need cardiac MRI, and the MRI characteristic will show what's called subendothelial late gadolinium enhancement is characteristic features of cardiac amyloidosis. Now biopsy is uncommonly used because they found by a retrospective study that abdominal fat biopsy will be positive only in 84% of patients with ALL. It's positive in about 45% of patients with TTR mutant type, and only 15%, very narrow ratio, in the patient with wild type of cardiac amyloidosis. ولهذا بطلنا نستخدم البيوبسي for diagnosis of cardiac amyloidosis. This is the biopsy. Once we diagnose, we have to do what's called genetic study in order to detect which person, one of the members of the family involved by this disease, to diagnose early and to treat early. So if you have a patient with amyloidosis, you need to do what's called light chain assay, as I mentioned for that, ذكرتها سابقا. Then we come to treatment. Treatment consists of 2 parts. One of them is to treat the underlying protein problem. The second part is to treat the symptoms of heart failure. The treatment of this disorder is limited and research is still in progress. The treatment differs according to the subtype. Treatment of heart failure, diuretics are the mainstay to control the congestive symptoms. Avoid ICE inhibitors, IRBs, and ARNI unless the patient has severe heart failure. IV, avoid beta blocker because they have bradycardia, heart blocks. Better to avoid beta blocker. Digoxin should be avoided because they are liable for digoxin toxicity. And if the patient has orthostatic hypotension, you can give him midodorine as to treat the symptom of postural hypertension. ICDC is controversial, and possibility the patient may get benefit from organ transplantations. And finally, we have the novel therapy in the management of cardiac amyloidosis. We have pitasiran and interferon, we have tafamidis, and we have what's called doxycycline and monoclonal antibody. Actually, each drugs, for example, those would act on the prevent synthesis of the protein, we call it as silencer, tishmalin and interferon and pitasiran. These act on the RNA to prevent synthesis of amyloid protein, while tafamidis act on the protein, prevent its disengagement, and finally, we can use doxycycline to increase damage of this abnormal protein. These are also our drugs are approved by FDA, and thank you for that.
Thank you. Thank you, Cardiac, for this presentation. Actually, amyloidosis is not rare, and we have families in Mosul with particularly transthyretin. See, the TAFA the drugs. Unfortunately, it is not available now, just for 6 or 8 months.
يمكن أنا والدكتور جاسم والدكتور خالد استطعنا أن نحصل من شركة فايزر تفاميدس. تفاميدس الحباية واحدة تكلف $1,000,000 والمريض ياخذ لازم طول حياته تفاميدس. فأنا عندي 4 مرات عالجهم تقريبا free from فايزر الشركة. الحباية تكلف $1,000,000 طريقهم صراحة. ف very expensive drugs.
المشكلة هو not available يعني not supplied by the company.
It's very expensive drugs.
اشتروه difficult يعني هو يعني does not change the natural course. It just cause stabilization and prevent the progression. Now the last but not the least, the assistant to Dr. Muhammad to present his talk about the new guidelines for management of cardiovascular diseases and pregnancy.
شكرا أستاذ خالد، شكرا للحضور الكرام. Guidelines for the management of cardiovascular disease during pregnancy. It is a broad subject. It's well known that many of hemodynamics occur during pregnancy, especially first 6 months. Overall, hypotension is so common despite increase in the plasma volume, despite increase in the heart rate, but there is increase in the peripheral vascular resistance, so the net results will be hypotension. 6 weeks post-delivery, everything will return back. Regarding the ECG, again, we have many of the ECG findings that to be considered normal during a pregnancy. That flat T wave may be misdiagnosed as ischemic heart disease, so common in ladies, pregnant ladies, and many of the intervals will be prolonged during the pregnancy. Echo finding, هنشوف كثير من التغيرات اللي ممكن يبعثون علينا بأنه small pericardial effusion, mild degree of mitral regurg, of tricuspid regurg, of aortic regurg, all to be considered normal, mild degree of left ventricular dilatation, normal. So these changes may occur normally during pregnancy. So we have a list of so important risky conditions that may be faced during the pregnancy. At the top of the list is pulmonary hypertension, so risky problem. We have DCM, that cardiomyopathy, especially ejection fraction is less than 40, and we have the obstructive, especially obstructive valvular lesions in the left side, especially mitral stenosis, aortic stenosis, pulmonary stenosis. Coarctation of the aorta may survive and may develop complication during pregnancy. Marfan syndrome, connective tissue disease, especially when aortic root become more and more dilated, and most of the cyanotic lesions, if they survive to become pregnant, mechanical is another problem facing us with the pregnant lady. لهذا السبب خلوا انه ريسك ستراتيفيكيشن، نقطة جدا مهمة انه نعمل ريسك ستراتيفيكيشن للبريجنانت ليدي. انه WHO او موديفايد WHO خلت انه ريسك من 0 الى 4، وهذه راح لكل بروبلم كارديوفاسكولار بروبلم فيسينج during the pregnancy، وهذا راح تفيدنا انه this classification and risk stratification will help in many things regarding the risk, maternal risk, the fetal risk. راح يفيدنا بانه when to deliver, how to deliver, overall risk. هذه كلها ممكن. ونقطة مهمة جدا انه what's called pregnancy heart team. الان العالم يمشي باتجاه انه تيم كامل obstetrician, cardiologist and hematologist to be sometimes in some special clinic disorder to be involved in these risks. And even where to be delivered, local hospital or advanced in centers, all these to be considered in certification. So, in general, what to do for the pregnant lady when you suspect cardiovascular disease? Echo is important. An imaging tool that should be done for a pregnant lady, especially if there is any new symptoms, dyspnea, chest pain, palpitation, significant palpitation, although this may occur in normal pregnancy. So echo is so important. Through measurement of BMP, brain natric peptide, already known case of the heart failure, of the past history of peripheral cardiomyopathy, or adult congenital heart disease, or some other conditions that may be exposed to heart failure, go for the measurement of BMP, brain natric peptide, to detect early heart failure in pregnant lady. CT scan can be done, yes, if you have a high suspicion of pulmonary embolism. The benefit to risk is to go for CT pulmonary angio. It will save the mother and the fetus. Chest X-ray, when all other modalities fail to detect the cause of the dyspnea, chest X-ray may be modality. CT and coronary angiography, even the coronary angiography, yes, it carries high risk of radiation, ionizing radiation, but with special shield during angiography, we can go, especially if we suspect some ischemic heart disease, namely spontaneous coronary artery dissection may occur during the pregnancy. If you go for the MRI, gadolinium may cause a problem, so please stop lactation 24 hours prior to the MRI. Again, in general, when to timing and mode of delivery. Normal vaginal delivery is the usual and the preferred and is recommended in most patients or pregnant ladies with stable coronary artery disease. What about systemic antibiotic prophylaxis? Systemic antibiotic prophylaxis, if there's suspicion, if there's a lesion that may be predisposed to infective endocarditis, is not recommended in normal vaginal delivery. Please don't be in hurry and induce labor prior to the 39 weeks. If everything is okay, we have stable cardiovascular disease. So 39 weeks of gestation is the timing for the delivery in stable patients. The planning is so important. We should have a pregnancy heart team for effective management of that. Especially, we have special problem. What about if patient or pregnant lady is already on anticoagulant? First, what about if lady on warfarin? Please stop it at 36 weeks of gestation. 36 weeks or 2 weeks prior to the planned delivery time of delivery. So what happens if the lady in need for urgent delivery within this time? We should check INR, we give fresh frozen plasma, we give even vitamin K, and then go for cesarean section for protection of the baby and mother. What if 36 weeks you stop warfarin, we change to the low molecular weight heparin. And if patient is at high risk of thrombosis, go for any fraction of heparin rather than for low molecular weight heparin. If we stop low molecular weight heparin and then deliver the lady, so we have to resume the dose we have to go for delivery 24 hours from the last dose of low molecular weight heparin. If we are on the low molecular weight heparin and want to shift to the unfractionated heparin, go to the unfractionated heparin 4 to 6 hours prior to the delivery, stop the unfractionated heparin. When to resume the dose, and you can go for the active management of the third stage of the labor with oxytocin. Everything finished, we can two things. First, we can postpone the low molecular weight heparin the oral anticoagulant 1 to 2 weeks, especially if there is problems regarding the wound. If we have a catheter in the regional anesthesia, please resume and restart the heparin 24 hours after removal of the catheter. What about hypertension? When we have a lot of the categories of the hypertension, gestational hypertension is well known, chronic hypertension. Gestation starts 20 weeks from the gestation and subside after 6 weeks. We have the chronic hypertension. We have chronic hypertension with superimposed gestational, and we have unclassifiable. We are not clear about the types, but when to consider hypertension? 140 over 90 diastole is the clear cut to define hypertension. White coat hypertension is so common. Please check home monitoring for blood pressure. Start treatment when readings above 140 and 190. What to do? Use methyl dopa, labetalol, calcium channel blockers, or can be used. What about low dose aspirin؟ نشوفها بكثرة بالكلينيك. فرع النسائي جامعة النسائي يكتبون اخصائيات نسائي انه low dose aspirin. Yes, if there is a risk factor for the preeclampsia, we can go for low dose aspirin. It is so, and even for those with high risk, we can start from the week 12 to the 36 to the 37 weeks of gestation with low dose aspirin. When the blood pressure becomes 160 over 110, please admit patient to the hospital. What to use? IV labetalol for emergency treatment of reduction of blood pressure. Nicardipine may be used. Methyl dopa can be used for the emergency. IV hydralazine is second choice. And if lady has pulmonary edema, give IV angiosin, IV nitroglycerin. If we have a preeclampsia only, if we have gestational hypertension, 39 weeks of gestation is the optimal for termination to induce labor. If we have preeclampsia, 37 weeks is recommended to end the pregnancy. If we have hemostatic change, please try to accelerate the timing of delivery. SVT, lady with SVT, pregnant lady, the same as non-pregnant lady. Hemodynamically unstable, electrical cardioversion. Hemodynamically stable, vagal maneuver, IV adenosine, IV beta blocker. So how to prevent it? Beta blocker can be used to prevent it. But if we have Wolff Parkinson-White syndrome, flecainide or propafenone can be used. Can we go for catheter ablation in a pregnant lady? Yes, may be used despite. Now it is mapping, not using radiation, the catheter ablation. So asymptomatic, severely symptomatic, recurrent, not responding to medical therapy, or cannot tolerate the medical therapy, or resistant to medical therapy, go for the ablation. So what about AF? AF may occur during the pregnancy. Pregnancy sometimes may be a risk factor for the AF. The same as non-pregnant. IV beta blocker, contraindicated or not tolerated IV digoxin to be used. What about to prevent it? Again, beta blocker is a good choice. And we can sometimes use what's called pill in the pocket. Flecainide, 2 tablets of flecainide can prevent or abort the attack of the AF even in a pregnant lady. coronary artery disease exclude